Welcome everyone to OSTEO Bites. We're so happy to see you here. My name is Christina Iptoma. I am mom to Osteo Angel Dillon, and I'm the Director of Scientific Programs for MIB Agents. And today on OSTEO Bites, we are talking with Dr. Michelle Ghert of McMaster University. Dr. Ghert will be sharing results from the Prophylactic Antibiotic Regimens in Tumor Surgery, otherwise known as PARITY, an international randomized controlled trial, which is the first ever prospective randomized trial in orthopedic oncology. And we have junior advisory board members Vicky and Andrew as our panelists today. Just a heads up before we start that Dr. Ghert's presentation today will include intraoperative images. So in case you get queasy from those, you might want to just listen to the audio. We are very excited to have Dr. Ghert on OSTEO Bites today. She is a full professor in the Department of Surgery, Division of Orthopaedic Surgery at McMaster University. She's a director of MacOrtho Research and co-chair of the Sarcoma Disease Site at the Juravinski Cancer Center in Hamilton. And she completed her undergraduate and medical degrees at Stanford University and Vanderbilt University, respectively. She trained in orthopedic surgery at Duke University and completed a 2-year fellowship in orthopedic oncology at the University of Toronto. She's been on the faculty at McMaster since 2005. Dr. Ghert has been selected to the presidential line of the Musculoskeletal Tumor Society and will be the president-elect in October of this year. Dr. Ghert's other research interests include the promotion of diversity and inclusion within the orthopedic surgery workplace. And then before we get started, I just had a couple of events that we wanted to share with you. For those of you in the Boston area, we invite you to join us for our first ever Mingle event of 2022. We promise it will be fun and there will be free drinks and appetizers. Everyone in the osteosarcoma community is invited. It's kind of like OSTEO Bites, but without the speaker and a lot more conversation. We'll put the invitation and registration link in the chat. And you can please share it with everyone you know in the Boston area. While we're there that weekend, we're also going to be hosting a Healing Hearts retreat for bereaved osteosarcoma parents on April 1st. Please email Casey. We'll also put her email in the chat for more details, and we'll put you in touch with her. And we'd like to thank our sponsor of this episode, BTG Specialty Pharmaceuticals. BTG provides rescue medicines typically used in emergency rooms and intensive care units to treat patients for whom there are limited treatment options. They are dedicated to delivering quality medicines that make a real difference to patients and their families through the development, manufacture, and commercialization of pharmaceutical products. Their current portfolio of antidotes counteracts certain snake venoms and the toxicity associated with some heart and cancer medications. Their drug, Varaxase, is for high-dose methotrexate toxicity. All right, Vicky, do you want to go ahead and introduce yourself?
Yeah, hi everyone. My name is Vicky Hoy, and I was diagnosed in July of this year, and I am currently still going through treatment, but hopefully will be finalizing and beating cancer by May. I will be starting at Villanova University in the fall.
Hi, my name is Andrew. I'm a junior in high school and a survivor. I was diagnosed 4 years ago, and now I'm a junior board member.
Thank you. Thank you for that incredible introduction. And I just want to say that this is an honor to be speaking to this group. I and my research group are very, very impressed, deeply impressed with your community, your organization. And we're really glad that actually helped us learn about your organization after you reached out to me. So we love working with patients. We really want to know what your experiences are so that we can make your care better. So and I'm going to be presenting the results of a trial. There are some scientific elements to what I'm going to say, but I will try to make it as clear as possible to those of you who are not physicians. And also, I would very much like to explain that this trial is one of many that's published on a daily basis in journals, but there's some things that are special about it. One, it's for people like you. It will help guide treatment for people with osteosarcoma. And also, it was the first time that people in my field, so you guys have had surgeons, and the surgeons they don't work together so much in research because, as you know, osteosarcoma is very rare. And so you end up working just in your center. But if you really want to do a trial and answer some really important research questions, you need to actually work as a team, not just with those in your center, and not even those in your region or country. You really need to go international because these tumors are so rare that it's hard to find out what the right thing to do is if you don't have the data or evidence. So yes, I will be describing the PARITY trial, or the Prophylactic Antibiotic Regimens in Tumor Surgery trial. I am presenting on behalf of the PARITY investigators, which is a very, very large group. I would like to thank the sponsors of this study. You can see from the fairly long list of funders that a major aspect of being an academic surgeon or physician is the attempt at finding funding to do your research. And so we spent a lot of our time writing grants. And so I'm very grateful to these funding agencies, and also to highlight Silver Hearts Foundation, which was actually a patient advocacy group that had funded this study. So why did we do this study? When we do limb salvage surgery, or surgery where we save the leg and don't have to amputate the leg, and we have to replace take the bone that was resected with a big metal implant. And you can see on this x-ray that there are some changes, especially at the femur at the top, where it looks like it might be loosening. And why would that happen? That's usually because of infection. So why are the infection rates so high with the surgeries that we do? Part of it's because the patients are immunocompromised, because, as you know, you're on chemotherapy and that affects your immune system. And also, these are big, long surgeries, and the the metal surface is very comfortable for bacteria to set up their shop there. So there's lots of things affecting and against us in trying to prevent infections. So what is the actual infection rate? How often does this happen? So we did a systematic review, which is where we scoured the literature to see what was reported so far. And you can see that in retrospective studies, so these are not trials, these are just people writing up their experience at their individual centers. The infection rate was 10%. And 10% it's not 90, it seems like it's low. But if you consider the fact that they are disastrous and very difficult complications, this is very high. If a patient has a total hip or knee replacement, for arthritis, the infection is less than 1% risk. So this is very high. So if you have an infection, you might need to be on antibiotics a long time. You'll have to have multiple surgeries to try to get rid of the bacteria. And you often end up with an amputation after a long journey of trying to eradicate the infection. This can affect your function and your quality of life. And if you have an infection and you need to be on chemotherapy, you might not be able to have the chemotherapy because you're actively infected. So these are things that we really, really try to avoid. So how do we do that? Well, we know that if patients get intravenous antibiotics around the time of their surgery, so within an hour before the surgery starts, the risk of infection decreases. So we know that perioperative antibiotics are critical. If you're going to have a knee or hip replacement, the recommendations by the various associations in orthopedics generally recommend 24 hours, maybe up to 36 hours of antibiotics after surgery. This is not the dose that you get while you're in surgery. This is after. So we asked the surgeons in the field that do what we do you prescribe 24 hours like the surgeons that do hip and knee replacements, or do you do something else? And you can see from this slide that surgeons are all over the place. About a third will give 24 hours based on what they know about the hip and knee literature, but many will go much longer, even over a week. And some people go longer than a week. So this is a lot of antibiotics for those people. And the reason why we do that, or some of us do that, is because we really don't want to have infections. So, but you have to balance that with, our antibiotics bad in some ways, or do we need to make sure we practice antibiotic stewardship, which means we minimize the chance of bacteria becoming resistant? The more antibiotics we give, the more chance that they will become resistant. So this goes back to the point that I brought up before I started. We looked at the level 1 evidence in the field, and level 1 evidence means studies that are done as a trial, prospective trial, meaning you randomize patients. It's a lot of organization, it's a tremendous amount of work. And how much of that evidence do we have in our field? And there weren't any of these trials that we could find in a systematic review. And so in that survey that we found out how much surgeons give antibiotics, we asked, would you participate in a trial? Even though we've never done one, would you participate to find out what the best thing to do for our patients is? And almost 90% said yes. So this was something that made us think, well, okay, let's go ahead and let's do this. It's never been done, but you know, there are all other surgical specialties and medical oncologists and cardiology, all the different types of doctors do trials. So this is something that's time for us to at least start thinking about doing, if not moving on it. So the objective of the PARITY trial was to determine if long duration or 5 days of antibiotics intravenously after surgery reduce surgical site infections compared to 24 hours. So this is in patients that are having a tumor resection of the femur or tibia and that are having an endoprosthetic reconstruction. Endoprosthetic means the big metal implants that are used to replace the bone that was taken out. So this study was designed by a group of experts in various fields. There's orthopedic oncology, but also we had to have infectious disease experts work with us and explain how long antibiotics were reasonable. We thought maybe 1 week for the longer arm, but they felt that that was not reasonable. It was too long. We need people to help us design a randomized trial. So we had specialists in clinical epidemiology and surgical trials, and also biostatistics. So this, even from the very beginning, this was a large group figuring out how to move forward. So we designed the study to be international because, as I mentioned, we need to have lots of sites involved. And it would be multi-center and randomized. Parallel arm design, that means there'll be 2 groups and the patients will be allocated by a randomization program online, meaning I can't choose what my patients would have. I would have to just log into the randomization system, and the randomization system that has been developed to balance everything out at each site would tell me what arm. Now, I didn't do that because it was the pharmacist at each site that randomized the patient and shrouded the bags, because it's important to blind anybody taking care of the patient to the outcome. This is because if I knew how much antibiotics the patient was getting, I might change my opinion of how their wound is looking. I would just be affected by knowing too much. It's better to focus on their care and all the other factors that are important, as opposed to being stuck on what antibiotics they're on. Blinding is something that's is considered fairly critical to randomized trials. It basically overcomes a lot of important biases. However, it's not always possible, but in this case, it was a possibility. So when you're determining if infection occurs, it's not always straightforward, because some patients have an obvious infection with, they're febrile, they got redness, they got pus. Sometimes it's more subtle. So we needed a committee to look at each of the cases of infection and to determine whether it actually did occur or not. Now, this central adjudication committee saw the data, saw the information, but were blinded to whether the patients were in the 1 or 5 day regimen. So this was important because at the end of the study, we had to feel comfortable that the decision on whether an infection occurred or not was not based on whether they had a lot of antibiotics or just a little. Also, we had to make sure that the patients were safe. So we had an independent data safety and monitoring board. And this committee is independent of the study. and was the only group that saw the actual data of the both groups that were unblinded. So they, at intervals, they met yearly and that quarterly reviewed all of the data to make sure that there was no concern related to one of the arms was doing much better than the other. So this study was organized at McMaster. You can see the blue box, but we did coordinate with a lot of people. So we coordinated with the Data and Safety Monitoring Board, the Central Adjudication Committee, and the Steering Committee, all the committees that I described. Plus, we also coordinated with the participating sites. So in the trial, patients were randomized to cephalosporin or cefazolin or ceftriaxone. These are antibiotics that we know are the best against the bacteria that tend to infect the arms and legs in reconstruction surgery. So the regimen 1, the patient received the antibiotics for 1 day and then 4 days of placebo, meaning they had an injection of saline, but they didn't know that because it was blinded. The other regimen was 5 full days, so a total of an extra 12 more doses because they were at 8 hours, every 8 hours. So this group, patients received 5 full days of intravenous antibiotics every 8 hours. So who were in this trial? So they were patients that had primary bone tumors like osteosarcoma. And there are also some soft tissue sarcomas that can eat through bone just the way osteosarcoma does. And they could have been included if they were undergoing the procedures that osteosarcoma patients undergo. There's also patients that have metastatic bone disease from other organs, such as renal cell cancer. And if they are undergoing a similar kind of surgery, then they would be eligible. So the primary outcome, meaning what we were really looking for, was a surgical site infection that occurred within one year of the date of surgery. We use the CDC classification, and this does end at 1 year after surgery, after which an infection is not considered to be related to the actual surgery.
Dr. Ghert, I just have a question there for you on
Yeah.
timing. Is there any correlation between time post-surgery and risk of an infection? So are you more, is it within the first month that you're most likely to develop infection? Does that risk decrease over time? Or is it the opposite?
It's a great question. And what we did find, and I'll show a graph, most of the infections were earlier on. It's not the next day. It's not a week later. It tends to be a month to 2 or 3 months later. There were some later infections. And that's a really good question. And our outcome was a time-dependent analysis, meaning the amount of time, the time taken to get infection was also taken into consideration. So does that answer your question?
Yes, thank you.
Okay, great. Okay. So there were many data points collected for each patient. And so that you need a really robust data management system that was managed centrally at McMaster. And you could only see, each site could only see the data for their own patients. So even though McMaster had access to all of the data, it was all blinded. So this is important that you collect the data prospectively, because if you just ask the site 2 years later, oh, what did you do for this patient and what kind of surgery did they have, then they're not going to remember. And even the medical records generally are not very helpful. So it's very important to add the data to the database right away. That way, you have data that is correct, accurate, and timely. So we had to work with each of the sites to make sure that the data was accurate, valid, and timely, so that there were 4 levels of data validation. So there's a lot of communication back and forth with the sites to make sure that they're keeping up with their data, so that at the end of the study, after the years of the study, we didn't have to go back to the medical charts, which would result in data that you don't feel so comfortable with. So this was truly an international collaboration. The majority of the sites were in North America, but we had sites in Africa, we had Europe, South America, and Asia, as well as Australia. So this was really truly international. There were 55 clinical sites that went through the startup process, meaning they were able to get through ethics approval and contract negotiations with our site. And 48 of those 55 ended up enrolling at least one patient. This was across 12 countries, across 6 continents, and there were over 150 investigators working on this. So you can see from this graph, the blue bars are the enrollment at each site per month. So that is, you can see overall over the course of from January 2013 until September 2019. So this is 6 years at least, that the enrollment basically increased. There were some months, particularly near the end, that we had lots of enrollment, and there were some that were less. And this is pretty standard for any trial. But overall, you can see there's a trend towards more enrollment. And that's because the gold line shows the number of sites that were collaborating. So you can see at the beginning, it was less, a little drop off. And then when people realized the trial was actually happening, they wanted to participate. So we were happy to have more and more sites work with us. And that's why the enrollment, that's why we were able to do this study, because of that gold line showing that people said, okay, let's all work together, let's do it. And so after a very long period of time, we finally finished all of the follow-up of 1 year in October of 2019. Oh, sorry, I need to move this. Enrollment completed in October 2019. 2020 is when we finished actual follow-up, but then because of the pandemic, there was some delay in getting the final data from some of the sites. So we finally finished all of the data accumulation in early 2021. So these are the results. We had 611 patients that were enrolled, so they were randomized, and it was 312 to the 24-hour regimen and 299 to the 5-day. So it was about equal. The reason why they're not exactly equal is because some of the sites did not enroll very many patients, and the randomization system was programmed to balance each patient at the site with another at the site. So if you only enrolled 1 patient or 3 patients, there would be an imbalance, but this is considered acceptable given the large number of overall patients. 7 patients were reviewed by the adjudication committee and found to be ineligible. And again, this adjudication committee was blinded, and so they were removed. So we had 604 patients that were included in the analysis. That it was 311 and 293. The randomization system did a phenomenal job of making the baseline characteristics or risk factors in each group equal. So that includes patient age, gender, race, location of the tumor, comorbidities, and surgical variables such as the time in surgery and the amount of soft tissue removed, the amount of bone removed, and various other factors. So we wanted to see if patients actually stuck to the regimen that they were randomized to. And if you go to the other side, it's called a crossover. So this actually was very uncommon. Only 2 patients crossed over, and those that went from the 24 to the 5-day regimen. So the other thing is that we found that there was a decent number of patients that left the hospital before 5 days, and you can't get intravenous infusions at home in general, unless it's 100% necessary. So, and this was not considered, for a trial in the real world, we weren't going to either keep patients in the hospital or send them home with an IV just for 1 or 2 doses. So, however, we were happy to find that the majority, about 84%, received at least 4 days, and that was equal between groups. Okay, so the primary outcome, infections. 15.9% of patients had at least 1 surgical site infection. So that is even higher than what we had thought it was going to be. And so this one finding in this study is that these indeed are very common complications. So in between the 2 groups, there were 52 of 311 or 16.7% of patients in the 24-hour regimen had an infection. And in the 5-day regimen, 44 of 293 or 15%. So as I mentioned before, we calculated the hazard ratio. That's a time-dependent risk outcome. And that determined that there was no difference. So all those statistics and all those p-values and confidence intervals indicates that there was really no statistical difference. If a hazard ratio is 1, it means there exactly is no difference. However, there's a little bit of noise in the system there. We're not sure 100%, but we're fairly close. And you can see from this graph, the number of every time the graph drops a bit, a patient has had an infection. So you can see that the infections are more common in the first 3 months and then level out. But if you look at the green and the blue lines, you can see that really there's nothing that will tell you that there's a major difference between the groups. So we did want to see if there were different types of infections that were different between groups, whether they were superficial, deep, or organ space. Those are the different depths of the infections. And again, there was no difference. We also did sensitivity analyses. These are done to make sure that you're comfortable with the results, and you take into account things such as death and amputation, because patients that are no longer alive or have had an amputation cannot get an infection. So that's what we call sensitivity or competing risk analysis. And also per protocol, meaning the patients that crossed over versus those that stayed in their group. And all of those sensitivity analyses showed us that we were comfortable with the results. We also did subgroup analysis, meaning were men more likely to do better with 5 days? Were osteosarcoma more likely to do better with 5 days? And there was no difference between the treatment groups. Now, these are subgroup analyses, and the study is not powered or it's not directed at answering these questions. So these can only be hypothesis generating. It doesn't really give you a definitive answer. We did look at antibiotic-related complications, and this is something that was also adjudicated. So 7% of patients had an antibiotic-related complication, and this is a complication for which they were admitted to the hospital or had to go under some intervention. Therefore, these are fairly serious antibiotic-related complications. 7% is not, it's almost half the number of infections. However, they are very serious. They were significantly more common in the patient group that got 5 days. So 5.1% of patients in that group had a serious antibiotic-related complication versus 1.6% in the 24-hour. And the hazard ratio is well above 1 in this, even with the confidence intervals, meaning we're at least 95% confident that there's a significantly higher risk in that group. The most common complication was C. diff associated colitis and also other types of diarrhea. So C. diff colitis is a very serious condition that requires long-term antibiotics and has a significant risk of relapse as well. Why does C. diff colitis occur? Well, the antibiotics that you get intravenously affect the microbiome, or the happy coexistence of the multiple bacteria in the colon and the GI tract. And so when you disrupt that balance, some of the more difficult, sorry about that, my computer's doing this, some of the more aggressive bacteria can overcome the weaker bacteria. And then that's how you get this Clostridium difficile colitis. And again, this just shows that there's a statistically significant difference. Also, we looked at unplanned reoperations. So you do the surgery, but you're not planning on doing another one. 25% of patients had to go back to the operating room at least once in the first year. This didn't differ between treatment groups, with a hazard ratio of 1.06. And not surprisingly, the most common types of reoperation were irrigation debridement. That means washing out and implant exchange and implant revision. These are the things that we do to try to get rid of bacteria. So most of these reoperations were done for infection. And again, the reoperation rates were not different across groups. The most common were implant exchange, irrigation debridement, implant revision. They had enough events that we could do a statistical comparison, and you can see that there was no difference between groups. Unfortunately, almost 30% had an oncologic event. That means they either had a local recurrence or metastatic recurrence. And almost 13% died within the first year after surgery. These oncologic outcomes, such as recurrence and mortality, were not different across groups. And the most common cause of mortality was disease progression. And again, this just shows the data between the treatment groups. The hazard ratios are all just very, very close to 1. So something that if it's 1, then the one group doesn't do better than another. So what is important about this study? We definitely believe that infections and avoiding complications from antibiotics are very important to patients and the healthcare system. So this is the outcome that we were looking at is something that's important to pretty much everybody that's involved. And we designed the study with all of the experts that helped us to reduce bias. And bias means that you're moving away from the truth because you have various factors that affect what you're doing in the trial, such as knowing what your patient is given, or knowing or being able to pick what you want for your patient, or not following your patient, and so you don't really know what happened. So we concealed randomization so that nobody knew. Everybody's blinded. So the patients, the caregivers, and even the people that assess the outcomes, which was the adjudication committee, were blinded. And even the statistician, the data analysis, did not know what group was what. And we used objective study outcomes. So we had the adjudication committee, which was blinded, determine an infection objectively and blinded, so that if the committee decided there was an infection, then that's the closest you can get to the truth. And we also interpreted the study results blinded. So we looked at the data and when it was analyzed, and we only saw group A, group B. We didn't know whether it was long duration or short duration. And then we decided how we were going to write the final paper based on if A is 1 day or if A is 5 days. So we did that ahead of time. So there was no bias in the interpretation of the results. And then we broke the randomization code. Probably the most important strength of this study is that we had multinational collaboration in orthopedic oncology. This is something that, as I mentioned, hadn't been done before, and it required a lot of work and sacrifice on the part of my colleagues and their research personnel to actually get the study done. We didn't lose a lot of patients to follow up. Aside from those that passed away, we only lost about 5% of patients, which is very good for a prospective trial over the course of a year. We included lots of patients that would be eligible, meaning these results could be extrapolated to a lot of patients that are being treated now or going forward. And we had representation from diverse healthcare systems. So we had in Canada, we have more of a socialized healthcare system. In the United States, it's more private or insurance based. And then in South America, it was different. So we were able to run this trial in lots of different kinds of healthcare systems. So that, again, we can extrapolate the results going forward to lots of different hospitals around the world. So there were some challenges, and they were many in getting this study done, but we overcame them. But the things to think about were that deciding an infection occurred is not straightforward sometimes. And the sites reported to us if they thought there was an infection, but there was also the problem with wound healing, which can lead to an infection. So we had to have the adjudication committee review in depth many cases to decide in the end whether there was an infection or not. As that was the primary outcome, of course, that was critical. So as I mentioned before, some of the sites, as osteosarcoma is very rare, so they may not have had time or the ability to enroll as many patients as other sites. So this did result in a somewhat of an imbalance in the number of patients in each group, because true randomization should end up with an equal. However, because there were so many patients, 600, that the known and unknown variables were, or at least the known variables were equally matched. We didn't follow patients after a year. You can get an infection, or called a late infection, after 1 year. Why does that happen? Well, the CDC doesn't think it's related to the operation. It could be related to bacteria that in your system that when you brush your teeth or you get a cut, bacteria gets into your system and then it finds the implant and then it sets up shop there. So we did not follow patients after a year, and we don't know if the antibiotic regimen would have affected that. And there were some wide confidence intervals, meaning we weren't the precise difference between groups. The hazard ratio was 0.93, but it did have some room before and after 1, meaning there's still a chance that we just didn't detect a difference. But the absolute difference was 1.7%, which is compared to an overall of 15.9% is very small. And if you want to reach statistical significance with that, to find a difference of 1.7 being what we call statistically significant, you need thousands and thousands of patients. And in our field, we don't really feel that that would be necessary, because the information that we have now should be enough to help you make a decision. And to do a trial of thousands of patients, you can see this trial took 6.5 years of enrollment. Thousands of patients would take, more than most of the time that we're actually in practice. So this is the best that we could do within our field. So the key findings of the PARITY trial, that we did not demonstrate a benefit of a 5-day regimen of antibiotics, intravenous cephalosporins, compared to 24 hours in reducing surgical site infections after the surgery to remove a sarcoma, a surgical resection, and endoprosthetic reconstruction. However, there was a significantly higher risk of clinically serious antibiotic-related complications if you were randomized to the 5-day regimen. So our message to clinicians is that when they're writing postoperative orders for the stay in the hospital, they can consider the uncertainty, the benefits. So we don't really know if antibiotics help, but we certainly didn't get any evidence to show that they did. And there is relative confidence in the harm, that meaning that we know there's a significantly higher risk for antibiotic-related complications. So I would like to acknowledge these are the sites that participated in Canada. I have 2 slides of American sites because they were very, very active. So this is the first slide and this is the second. And we're very grateful for our American collaborators and working together with them internationally. These are the sites that participated internationally. And just as an end note, these are pictures of I and my team. We traveled around the world to conferences and to different sites to ensure that the trial is going well. But at the same time, we developed friendships. And there's a very unique bond between surgeons that take care of patients that have challenging problems. We really try to help each other through the processes and to learn from each other and to improve our care of our patients. So these are just some pictures of us having fun, and learning from each other, and basically becoming friends. So it's almost brought an international circle of people very close together. And, it's probably the most enjoyable part of this kind of research, is working with people that speak many different languages, but we all speak the same languages of helping our patients. So the PARITY trial was published in January of this year in JAMA Oncology. And so it's actually full open access. So you don't have to have a library registration to pull the paper. This is the first, this is what it looks like. You can download a visual abstract and editorial, and there's also quite a bit of supplemental content. And just for fun, we thought we'd show the authorship list. So these are the basically hundreds of people that participated and contributed to this study. They all have, they are what we call indexed on PubMed, meaning they get credit for actually being part of this study. Thank you.
Thank you so much, Dr. Ghert. It was like a cliffhanger until the end.
I know. When I presented it initially to our society, no one had seen the data except for the writing committee. So it was pretty exciting.
Yeah.
After all those years.
That's amazing, and also amazing enrollment. 600 patients is impressive around the world.
Thank you. Thank you.
So please, if you have any questions, feel free to put them in the Q&A. And then I think our panelists have some questions.
Is there a reason why the study focused on lower extremity reconstruction instead of upper extremity?
Very good question. Yes, we looked in the upper extremity. The infection rate is actually much lower than in the lower extremity. You can get an infection in the upper extremity, but the risk is so low that there's nowhere near as much, I guess, overall stress about it. we did consider that, but the event rate is so low, which is good. Why is that? Part of it is probably the larger surgery in the lower extremity. The bacteria that hang out on the skin and in the groin and in the leg are different than in the shoulder region, and they tend not to be as much of an issue. So the steering committee just, of course, all these things came up. There's a great question, and the steering committee decided that there wasn't enough clinical evidence to include upper extremity.
And then Ryan, did you have a question?
Yeah, I do. So my question is, does it make a difference whether it's an oral or IV antibiotic?
Good question. So we do know that intravenous antibiotics have better, what we call penetration of the tissue. It goes right into your bloodstream, goes right to the surgical site. When you have oral antibiotics, there's a period of time where it's in your stomach and then it gets absorbed, and then you can actually, it doesn't have as rapid or intense accumulation at the surgical site. So at the time of surgery, for sure, when the risk is highest for bacterial contamination, I would say that intravenous antibiotics would be standard of care across the board. Some people discharge patients on oral antibiotics, again, because they're so scared of infection. There is some discussion, if you already have an orthopedic infection, can you be treated only with oral? And there was a recent study published in the New England Journal that felt that maybe you didn't need to have intravenous, but this is for people that already have infections. So intravenous antibiotics have higher risk for complications, but they also are much more impactful at the time that you actually need to have them.
Dr. Ghert, I remember actually Dylan had, because he did have to be on antibiotics, I remember, for an extended period of time. And he actually had those great balls that you, since most patients have a port that you can kind of self-administer at home.
Yeah.
So I know you had mentioned some patients didn't finish all their doses because they were discharged for 5 days, but I don't know if this particular drug, the cefazolin, is available in that format, but I don't know, was that something, or is that?
Yeah, you could have done that, though not all our patients had ports, because there are some bone sarcomas that aren't treated with chemotherapy. And so it would have been, only selected for some patients that had a port. I think that's a reasonable possibility. It just couldn't have been, it wasn't what we call real life or pragmatic, that, to arrange for a couple of doses of antibiotics at home would just never happen in real life.
Right.
Meaning outside of the trial. And unless you had an infection, then you have long-term antibiotics. Then if you either get a PICC line or a port, so you can get antibiotics at home. Does that answer the question? It's a good question. It's just the design of the trial was meant to be, the word we use is pragmatic. So it's not so much of an experiment as what happens in real life if you prescribe 1 day? What happens in real life if you prescribe 5 days?
Yeah. Well, and especially now that we know that the 24 hours is sufficient. Not really an issue.
Yes, exactly.
All right, great.
The next question was, what are ways that you can minimize antibiotic resistance?
Great question. I guess the simplest answer is don't prescribe antibiotics unless they're needed. So this unless they're needed is a pretty broad expression. If a patient has an infection and it's obvious that they're infected and there's a bacteria that you've been able to culture that you can treat with antibiotics, then the patient should get antibiotics. But a lot of doctors give antibiotics just because they're worried about something that's going to happen. And so if around the world we said, okay, we really need to steward our antibiotic prescription, if our governments or regulating bodies said, okay, we're going to review your antibiotic use every year, I think that there would be less of an issue. So the resistance develops because you give too much antibiotics, you give them for too long, and you give too many different kinds all at the same time, so that the bacteria, they really start figuring out how to get around it. So in the United Kingdom, they stopped using cefazolin because of this C. diff problem, and that they actually won't let the surgeons use cephalosporins there. So so they have less C. diff. It has to come from the government. It has to come, you know, so we are allowed as doctors to pretty much do what we want. We all believe we're doing the right thing, but there's nobody, you know, we're not regulated in that way.
So kind of following up on that, because I know there are some other issues, like, for example, Dylan had some allergies to certain antibiotics. So they were always kind of trying to figure out, though, again, like clindamycin was, I think, actually the one that was used most frequently.
Yeah.
So I am curious, and maybe this will be like a future study, but like type of, like, what is the standard for the type of, I mean, you mentioned cefazolin, though I don't think, I don't remember that one ever being in our arsenal. And so what class of antibiotics work best? And are you kind of looking for broad spectrum antibiotics, or something that's more that, you know, works specifically on these infection sites in the...
Right. And that's a really good question, because it wasn't just the standard bacteria that we were finding in the study. So most orthopedic infections, certainly not all, but most are Staphylococcus. They're either Staphylococcus epidermidis or Staphylococcus, one of those. So I'm totally blank. Anyways, it's staph. And so they are susceptible to cephalosporins, and cephalosporins is basically like, it's like penicillin, but much more developed. And so those are the best antibiotics for those bacteria. Also, so cephalosporins also have a broader spectrum. They actually have impact against gram-negative, which is staph are gram-positive. So it has a reasonably good spectrum. It's not as broad as some other ones, but cephalosporins are considered fairly broad. And we did not us, but our colleagues at McMaster did a survey of North American surgeons that do hip and knee replacement, and ask them, you know, what antibiotic do you use? And 95% use cephalosporins. So as a pre-op or intra-op dose, that is the standard of care. I prescribe clindamycin if the patient has a true penicillin allergy. It does have really good absorption in bone, but it doesn't, the spectrum's not quite as good as cephalosporins.
Did you and the other investigators find that patients were hesitant to consenting to this study, knowing that they could be randomized to receive less antibiotics?
Good question. Very good question. I think it varied by site. So at our site, we had 90% acceptance. I'm trying to remember the reasons. You know, most people were like, yeah, you know, you just consented somebody to rearranging the anatomy of their leg, and then you ask them for one more consent. And, you know, for them, it's so small compared to what you're actually doing. I do believe that the patients that declined are the ones that wanted more. So there were some sites, and I think it is different. So as I said, different healthcare systems, United States, the patients, you know, they're paying for their care, so they want everything. And in Canada, you know, socialized, and they don't have an issue related to you know, they're paying for it, so they want the best. They're just happy to get care because, you know, they don't have to pay for it. And it's, you know, in Canada, we have excellent healthcare. So I think that's why we had not as much of an issue. There were some patients that didn't want 5 days, because my standard of practice is 1 day. So, I mean, this was before the trial. So they all asked, you know, what would you do? And so some of them said, well, I don't want 5 days. So overall, the consent was, most sites did very well with patients agreeing to participate. And so we particularly had a really good experience. I find that patients in general are really interested in participating in research, which is great, because if we don't do research, we can't improve the care of patients. Can you imagine if the COVID vaccine, you know, if people just didn't want to participate in those trials, where would we be now? You know, so the patients have to be comfortable. There's no way, we're not pushing them into anything, but for the most part, the ones that I've worked with feel that they want to give back to the healthcare system. So a good question. It's always a challenge, because, you know, I know both arms are safe. I mean, I thought 5 days was pretty safe, but obviously maybe not now. And any patient that I enroll in a trial, I'm comfortable with all of the arms. I know that that there's nothing that I know of at the time that's going to make a difference as far as their safety.
What's the antibiotic protocol for treating surgical site infections?
So what you do is if you have an infection, you most likely you're going to need surgery. So we would go in and we would culture the tissue to see what bacteria is there and then direct the treatment based on the bacteria. In the interim, you would probably get either a cephalosporin or vancomycin, which is a very strong antibiotic against gram-positive, which is what you're thinking it's most likely going to be. And then once you get the culture results, you decide what to go do from there. So, and if it is a true surgical site infection, like the implant is infected, then the surgery will involve a lot of removing of the implant. You put cement in, and then you'd probably need several weeks of intravenous of those antibiotics. So once you have a deep infection, that's when you say, okay, we really need to be aggressive now because something happened and the patient needs aggressive treatment. We really want to save the leg, or in this case, leg or arm in other cases. Our job is to, we always tell the residents, we save a life, save a limb, and give them good function. So obviously function is very important, but you want to save their life, you want to save their limb, and then you want them to be happy with what they have left.
I saw that you had colitis on one of the sides, and is the one who ended up having that as like a complication of long-term use. How long does it take for your microbiome to like fully recover after this disruption of long-term antibiotic use?
That's a great question. I believe it could take a year or two until you stop relapsing from C. diff. I guess it depends on how you can be treated. We do treat C. diff, but if you have other complications related to chemotherapy or surgery, you may have to go off them for the treatment for a while. But I would say the microbiome will take a long time, 1 to 2 years to recover.
Dr. Ghert, I'm curious, this seemed just like a very successful trial effort in terms of how many sites enrolled and physicians participated. And it being the first one, does this kind of set you up to be able to do another type of study like this?
Yeah, great question.
Structure set up. Yeah.
Yeah,
and what's your next question, I guess, that you
Yes, we have started another trial, and a lot of the sites are participating. We did a Delphi process, which is a consensus-based process a few years ago, where we asked everybody that we knew around the world in our field and patients in different centers, what's a research question that is important to you that can affect our practice and that we can answer. And the process took, I think, 18 months. And the last step was an in-person meeting. And then we published the results, and the number one priority was for soft tissue sarcoma, so not osteosarcoma, how to follow patients. How often should we see them? Should we do chest x-rays, CAT scans? Because soft tissue sarcoma is different than bone sarcoma. It doesn't respond to chemotherapy. So you can have metastases, but knowing about them is not really very helpful. But we still follow our patients very intensely because we're used to that with the bone sarcomas. So that was the number one question. So we started that trial. It's called the Surveillance After Extremity Tumor Surgery Trial. And we have 21 sites that are open so far. And we don't need as many sites because soft tissue sarcomas are more common than bone sarcoma. So each site will have more soft tissue than bone. And so we've enrolled about 115 patients so far. So it's not 600, but we were doing pretty well. And I do think that, PARITY was successful, but there were many days and weeks and months where it was very difficult. The challenges did not seem like they were surmountable. They were, there were many days that, I didn't know if it was going to actually finish. And so the same thing with the current trial, we have tough days, or tough weeks, and we just keep pushing because there's no option. If we don't do these trials and I retire at some point and nothing happens, then there's nothing to help the patients, because we're just going to keep doing what we're doing, and as opposed to maybe making things better.
What is the risk of infection if a patient has other types of surgeries like lung surgery?
It would be much lower. I think we're trying to tease out the risk factors, like really what causes infection. But in general, the more complex, the longer the surgery, the higher the risk for infection. So thoracic surgery, when you're resecting, metastases or a rib, it's fairly short. The other thing is we put in implants, these big metal implants. They are just a magnet for infection. If you're not putting an implant in, the risk is pretty low. So I would say that if you're having a metastatic, if you have a nodule in your lung and you're having it taken out, it's got to be less than 1%. It's not very common. Yeah, the infection risk is pretty unique to our specialty, to our patient population. And I think that's why the research question resonated with so many people around the world, and they were willing to participate in trying to figure out the best way to prevent them.
So are there, I think they're like coatings and stuff like that, but are there different materials, and now with like 3D printing, that are just less susceptible to infection?
Yeah, there are some implants that are silver coated, or some are trying to antibiotic coat the implants. The evidence for that being effective is just not there. A lot of people believe, they'll swear up and down that's the answer, and then but there's no evidence to support it. I do think that the risk for infection is so multifactorial that the implant surface probably is not the key factor in reducing infections. They're also more expensive, and so certain healthcare systems will not support them. And yeah, they're only available in Europe. So I don't know, it just hasn't, the FDA is just not comfortable with them. And if the FDA is not comfortable, then I'm not. But it's a good question, like, what can we do? Do we do something on the implant? Maybe that's the answer, but we haven't found it yet.
Okay, next trial with like a
yes, someone else's career. We're trying to teach people how to do these things so that this becomes part of what we do as a society, as opposed to just one center. And I think it's happening. It's working. It's going well.
Yeah, well, especially as you said, for rare disease, it's it's hard to get the numbers to actually have something with statistical significance. So thank you so much, Dr. Ghert, for spending an hour with us today.
My pleasure.
And for your commitment to osteosarcoma patients everywhere and making it better. More information on this episode and all OSTEO Bites can be found on YouTube, our YouTube channel, on our website, mibagents.org, and your favorite place to find your podcast. And if you did register for this session, you will get an email with all the links mentioned today, including just a link to the paper, Dr. Ghert, that you mentioned. And we can also share information about the other trial as well. Next week, we are going to be talking with Elena Gerasimov from Kids Beat Cancer about compassionate use of investigational drugs. She'll give an overview of the compassionate use program, and explain how to apply for experimental drugs, and discuss the resources available to both patients and doctors throughout the application process. Thank you again to Dr. Ghert and our panelists, Vicki, Andrew, and Ryan, and to our sponsor, BTG Specialty Pharmaceuticals. And thank you all for joining us today. We hope to see you next week.